Welcome, everyone who's joining us. It's so good to have you with us today. We'll be starting in a couple minutes after we allow time for everybody to join. I want to welcome everybody as people are joining. It's good to have you with us for the Midwest Town Hall. So I think I'll go ahead and get started. Welcome, everyone, to the Compassion and Choices Midwest Town Hall. Thank you for being with us. My name is Karen Retzer. I am the Midwest organizer, and I am looking forward to hearing from our leader, Kim Callanan, President and CEO of Compassion and Choices, and Amy Sherman, the Midwest Advocacy Director, about the end-of-life care and options movement and what Compassion and Choices has been doing nationally and here in the Midwest. I will now turn this over to Amy, who will ask some questions of Kim. Amy.
Well, first of all, thank you all for joining us. We are very thrilled by the response and interest. It says a lot about our movement. And I just want to thank Kim for joining us as well. Kim, I've asked you this before at town halls. I'm going to ask you again. Could you just tell us a little bit about yourself and what brought you to Compassion and Choices and your whole journey to become our president and CEO?
Oh, thanks, Amy. Well, first of all, I just want to say welcome to everybody who's joined us today. How delighted I am to be here, and to thank you and Karen for inviting me. It's always a pleasure to get a chance to talk to our incredible supporters. I came to Compassion and Choices like so many people did, with my own personal experiences around the end of life. In my case, I had a grandmother who had an advance directive that wasn't honored, and that was a really horrific experience where I just, she died and I felt like we had let her down. And to the kind of look on her face and her watching her tear, cords out of her, it just, it was very unsettling. And then you fast forwarded to my grandfather's death, and he had a beautiful end where we got a chance to say goodbye. And that was when I realized that how one dies matters, not just to the dying person, but also to those who are left behind. And I've now seen my story, both of trauma etched in people's mind, as well as the gift of closure in hundreds of thousands of people across the country. And it has just affirmed my commitment to ensuring that people get care that's consistent with their values.
Thank you. It really reinforces just how personal this is for all of us. The board of directors recently approved an updated strategic plan. I know it took a lot of thought and effort, and this is going to be taking Compassion and Choices through the next 5 years. Can you just share what are the top priorities, and are they new or different from the prior plan?
Thank you. And I am really excited about the new strategic plan. We adopted the last strategic plan right after I became the CEO. So it's kind of, I can't believe I've been the CEO now for 5 years. I still feel like I'm a baby or an infant in the role, but apparently I'm a toddler now. And so it was really exciting to go through this process and to have 5 years of experience under my belt, but also this incredible team and connections to the incredible volunteers. And so the robustness of the plan is really a reflection of the strength and growth of the movement and the talent that's there. And I'm really excited because what this plan is about strengthening an already strong movement and lifting up what's working well and focusing in on that and growing to ensure that we're diverse, inclusive, and represent the full breadth of people's needs at the end of life. So what we did this year is the mission, vision, values did not change. They're identical to what they were before. Our goal was really to hone in on the long-term objectives so that we continue to have a 10-year horizon about what is it that we need to do in order to ensure that this movement continues to move forward. And our mission has always been to improve care, expand options, and empower everybody to chart their own end-of-life journey. And this year, for the first time, we organized our long-term objectives under each of the aspects of our mission. And it seems like such a logical thing that you're sort of like, well, why weren't you doing that all along? But we weren't. And so this year we did. And so we have improve care, expand options. We added defend options, given what we're seeing in all of the bodily autonomy movements, as well as our own, the need to really make sure that protection is a top priority, and then empower everyone to chart their own end-of-life journey. And then we put long-term objectives under each of those. And I'll start actually out of order with empower everybody, because I think that's the work that people are most familiar with that we do. And in the empower everyone, it's still about ensuring that we authorize, we make medical aid in dying accessible and authorized to 50% of the country by 2028. So that's remained the overarching goal. But this time around, what we did that I love so much is we're starting to take a regional approach so that we recognize that we need to bring medical aid in dying to people in every region of the country and make sure that there are within those regions states that do not have a residency requirement so that no state or person is left behind. And of course, no one wants to travel to another state to access the law. So we know we need to ultimately get in, all states eventually. But in the meantime, we also realize there's a small group of people that are willing to travel for it, and that is an important priority. And so we want to make it accessible to them. And what that means is, if you look at the country right now, what that means is that this Midwest region is essential. We have got to, absolutely have to authorize a state within the Midwest if we're going to advance and move this movement forward in the right way. So that's the kind of medical aid in dying. And we also are going to look at a strategy to ensure the issue doesn't become polarized so that in any kind of state, we're able to depoliticize the issue. So that's something we're setting a longer term objective around. And that's really important work. And then we have efforts around defense, improving care, and expanding options. And I, could talk about all of these for a really long time, but I know we have a limited amount of time, so I'll wait to see what questions people have.
I can tell you, I am very excited about all of this and ready to get working on all of it. I know some of this is going to take time and patience, but a lot of it we're very well positioned to do. So I'm thrilled. Thank you for sharing that. I do want to talk to you also just specifically about medical aid in dying. A lot of people are interested in what's happening in the legislatures, and we are wrapping up legislative sessions in the state. So what do you see as the most exciting and promising developments, and also what have been challenges around medical aid in dying this year?
Yeah. So on the most exciting front, it's that we've firmly seen now that once you authorize medical aid in dying in a state, that almost immediately, within a year or so, lawmakers quickly realize that all of this concern was for nothing, that the law is incredibly meaningful to their constituents. And now you can have real conversations about how to improve the law so that eligible people are truly able to access it. And so this legislative session, we saw improved bills in Washington State, in Vermont, and in, oh my God, what was the last state? Hawaii just authorized an improved new law. And they're doing things different in each state. Some states are removing the residency requirement, like Vermont did, with a recognition that we need to ensure that we welcome people from other states into our state because we see this as a value and we don't want to leave people behind. But in the states that are looking for greater access, you're seeing a move towards allowing APRNs to be able to practice. And in many states, APRNs have full prescribing authority, and it's a very logical, normal part of their practice. And so to make it available, make it so that APRNs can participate as well will be huge and game changing from an access perspective. And then there is a recognition that the waiting period is a suffering period. And for a dying person to get through this very onerous law is resulting in about 30 to 50% of the people dying unable to access it. And so while early on, people are talking about a 15-day waiting period, a 30-day waiting period, and the conversation within legislatures is really kind of about more in terms of regulatory roadblocks. There starts to be a different conversation in legislatures after they really see firsthand just how difficult it is to access the law as written. In terms of what's challenging, in the states that have an authorized medical aid in dying, they haven't moved beyond this ridiculous conversation that, abuse and coercion will take place. And the opposition has really come back very strong. They have been emboldened by the reproductive, their wins in reproductive rights, and we're against the same opposition. It's become very, very polarized, and that makes it harder. But we're going to prevail because we ultimately have, the power of people on our side, and we're making that progress. And we also have an issue that is not partisan to dying people. And as people have that firsthand experience with death of a loved one, they move from not understanding the issue, not caring about the issue, or opposing the issue to being an advocate. And so our support is going to continue to grow.
Very much appreciate what you just said. And, again, this takes time. This is sometimes a multi-step strategy to make some of the progress that we're talking about. But the nice thing about Compassionate Choices is we're in for the ride. We're not there for quick wins. We're there to make real systemic change. So let me ask you, there's states where we know that, a question came up. What is APRN? Can you just?
Advanced Practice Registered Nurses. Thank you for asking that. I'm sorry. I have to remember not to talk in lingo.
It's hard not to, and I didn't ask you. And I think it's important to know APRNs are really functioning in a very similar role to physicians. They do have that prescribing power, and this fits very much in their scope of practice that they're allowed to do.
And I would just clarify, Amy, that their scope of practice is different in every state.
That's a good point.
And we really take our lead on the state and what their scope of practice is within the state. And so in the places that have passed it, like Hawaii, APRNs have a very robust, but there's been other states we were in, like when we were in California, where their practice is just different. And so we do defer to local expertise around what the scope of practice is, but hope that the scope of practice for APRNs continues to grow, because we know from data and from practice that nurse practitioners really understand the bedside experience and tend to be more supportive and more willing to support their patients at the end of life with medical aid in dying.
Yeah, and I think for many of us who are waiting to get a doctor's appointment, we understand sometimes access can be an issue, and particularly if in a rural area, it can be very difficult. So there's some real practicalities to this. Well, let's move on. What do you see as priorities for states where medical aid in dying authorization is not on the near horizon?
Sure. So I think there's a couple of real priorities or possibilities, and this goes to other aspects of the strategic plan, which I'm really excited about. So I talked about the improved care and the empower everybody to chart their own end of life journey. And both of those things are critical in states that are farther off. And actually, I would argue introducing medical aid in dying legislation early, you're just going to go up against a brick wall, and focusing on other strategies will result in both a stronger movement, but you'll also see improved care. And so just something for people to think about when you're thinking about what your strategy is. I'll start first on the empower everybody piece, but in this year's strategic plan, we set the intention that within 10 years, we would have 100,000 empowered consumers. And what we're going to do is create a roadmap of what it means to be an empowered consumer. And I think a lot of times people think about an empowered consumer and they assume it's just about filling out an advance directive. But what we know is that it takes much more than an advance directive to stand up to the default mode within our medical system and overcome kind of this bend towards all available treatment or to get the kind of treatment that you want. It takes really knowing how to advocate for what you want. And first being clear about what you want, whether that's lots and lots of care or whether that's, palliative care or just pain and symptom management. And to understand that is really challenging. So we know what all of those things are, but what we hear over and over again is this is a lot and it's really confusing and we don't know how to do this. And so we're going to create this roadmap on what it means to be an empowered consumer and help people build that muscle and build a curriculum around it. And then we're going to inspire people to become empowered consumers. And what we know is that when you're an empowered consumer, that you have the potential to change medicine through the interaction between the patient and the doctor. So what we hear over and over again from doctors is the very first time I considered whether or not I like the patient's perspective was when someone asked me about practicing medical aid in dying and whether I would do that for them. And I didn't know anything about it, but that was what opened my mind up. And so if you think back to the childbirth movement, there was this transformation within the childbirth movement that was very similar, where women used to have no say over their childbirth experience, but they started to demand a different kind of childbirth experience. And that's what resulted in women now having doulas by their side or natural childbirth or saying, no, give me all the medicine. But whatever it is, you see much greater likelihood that women are making those decisions. And that's the kind of transformation that's already afoot in end-of-life care. But by us creating this empowered consumer roadmap, we're going to increase that. And so what we're hoping is that states will join us in taking this pathway to being an empowered consumer and go out and train other people in how to become an empowered consumer. And we want to create a train the trainer program. And so we'll start small with just like a simple PowerPoint and that everybody can deliver while we're building the roadmap out. But we want to get people involved in this movement by teaching them how to be better consumer advocates. And that is something that will allow us to reach more populations, because when we do it, it's really important we don't put a value on what it means to be an empowered consumer. For some people, being an empowered consumer may mean having a hospital death. For other people, being an empowered consumer is going to mean understanding, is going to be foregoing treatments. And it's not our value, it's the value of the person. But what's missing right now is people don't understand the benefits and the burdens. It is presented to people as if your choice is, live and fight till the bitter end or die. But the reality is there's a whole bunch of gray in the middle, and fighting until the bitter end often does mean having a really debilitating end. And we're not presenting the true choices to people. And that's what we want the healthcare system to do. And we want people, through being an empowered consumer and asking questions, can transform healthcare. So that's one thing people can do, is focus on creating a network of empowered consumers. We also have an aspect of our strategic plan that's around improved care. And there will be a federal policy agenda that we're advocating for, where there will be changes to the federal system. One of the things I'm really excited about is the potential. We saw a pilot program take place where, if right now within hospice care, a very small percentage of people actually access hospice care, and they're only on it for maybe 7 days, 15 days, like they really don't get the full benefit because people are uncomfortable with this idea that they have to forego curative treatments. There was a pilot that was done through CMS, the Center for Medicare and Medicaid Services, that showed that if you didn't force people to drop their curative treatments and they went into hospice care, that at the end of the day, once they're on hospice care, they ended up choosing less care on their own, and they were on hospice care for far longer and had higher customer satisfaction. So that model exists. It's proven to be more cost effective. It's proven to have better outcomes, but it hasn't advanced towards a change in federal policy because of our political system. But that's going to become one of our top federal policies. And so what we need people in states to do is to organize to help us at the federal level advance legislation that's going to impact every single state. And there'll be other things to it around inequities that gets addressed. And that ultimately will help build a robust network of advocates, and that will put pressure on the system as well. And you'll be able to turn those advocates from the federal level to the state level when you've built the right grassroots momentum. So those are some examples. There's so much more, because there's so much more robustness to our strategic plan. There's defense opportunities, there's emergency medicine and palliative care, but I'm going to stop talking because I know we have limited time.
Well, I hope those of you in states where there may not be activity around medical aid and dying, and even in states where it is, I hope you're feeling excited, because I mean, just listening to this, there's a lot of really great work that we're going to be taking on, and we can't do it without you. So I'm really thrilled. Let me ask you, just speaking about empowered consumers and advocates, what are 3 concrete things that the supporters, people like the people here today, what can they do to make a difference in their community? If you had to give them 3 suggestions.
Sure. So the first thing is to get involved at the local level with your action team, and be a part of this grassroots movement, which, I think is just essential. And it's everything from making phone calls to doing online actions. Like, you can decide how much time you want to participate. You could be someone who's helping to organize, or you could just be someone who occasionally goes online and responds to emails. But, volunteer advocacy is key. That's needed at the state level. We also have opportunities for people who want to be volunteer advocates and have special skill sets to serve as an executive volunteer. But the first thing I would say is to volunteer your time. The second thing that I would say is, if you have a personal experience, it would be to share your story. And sharing your story is such a compelling way for us to lift up the movement. And we need all kinds of stories. We need positive stories around good deaths. We need stories that demonstrate the need for medical aid and dying. We're going to have stories that demonstrate the need for improvements and changes to hospice care. Like, we need a whole robust array of stories. And so, to step forward and be willing to share your story to demonstrate both the value of good care and the need for improvements to care. And then the third thing that I would say is to make a financial contribution. And that can either be now in your lifetime, or it could be as a legacy gift. So I often hear from our supporters, I just don't have capacity right now to be able to give. And that's okay. If you were to add us into your will, or you can really simply make us a beneficiary of your life insurance or your IRA. I did my change. When I became the CEO, I was like, I better put my money where my mouth is. And I made the change to my IRA, and it took me about 10 minutes. So it can be done very quickly. Outside of all of the kind of wills, or you, of course, can go through a longer trust in the state process. But those are 3 simple ways that people can get involved in this movement. And it really, really, really is a people-driven movement. We are up against such powerful opposition that is entrenched with centuries and years and of experience and money and resources. And we are about individual people and about the heart. And if we can capture the heart in our stories and in our energy and in our passion, our progress will continue.
Thank you so much. Well, do you have any final words or thoughts before we move on with the program?
I just want to say a huge amount of gratitude to everybody. Often people will say, what do you love most about your job? And what I love most about our job is that we have the most incredible supporters, volunteers, donors, people who send the sweetest notes thanking us, people who really believe in the work. It is so different than other organizations that I've worked at, but I guess, we're not the sexy issue where people get involved with us because, they want their name on a building or because it's like this sexy thing. People get involved with us because we are on the right side of an issue and because it matters. And, the kind of people who are willing to get involved with an issue that's a little bit more out there, you're more courageous and you're like strong about who you are. And that makes you like super inspiring to get a chance to work with. And we're up against so much, like it's so hard to raise money and it's so hard to have the opposition out there having so much more than you have and being so aggressive. And it's so hard to have storytellers that you love die and to know you didn't get them their option. But what inspires me to keep on going is the connections that I make with individual people. So I just want to thank all of you, whether you've sent a little email to me or to a staff person saying thank you, or you've sent a contribution, or you've invited us to your home to come present, or you've made a connection to another organization. Like it's the culmination of these acts that ultimately is what is inspiring this movement. And from the bottom of my heart and on behalf of the board and the staff, I just want you to know that that matters and it makes a difference and we really appreciate you. So with that, I'll turn it back over to you, Amy and Karen. Thank you.
Thank you.
Thank you so much, Kim. Thank you. So informative. I want to let everyone know that we are going to be doing a Q&A at the end of this program. And I know some people have started asking some questions, and that's wonderful. You should see a Q&A button at the bottom of your screen. So feel free to start writing questions now, and we will get to as many as time permits towards the end of this program. But now I want to ask a few questions of Amy Sherman, the Midwest Advocacy Director. So Amy, what is your role at Compassion and Choices?
Well, as Midwest Advocacy Director, I am responsible for our legislative strategy and serve as the primary contact with state legislators. I also work with our team on voluntary recruitment and engagement, ally building, community education, just throughout the region. In addition to advocating for medical aid in dying, we promote advanced care and dementia planning, effective hospice policy, reduction of healthcare inequities, and other issues that empower people to chart their own end-of-life care. As Kim said, all of this work is about moving to a people-directed approach to healthcare. So everything touches upon that greater goal.
Okay. And we've got a whole group of people throughout the Midwest, but what states comprise the Midwest region?
Well, there are 9 states, Kansas, Iowa, Illinois, Indiana, Michigan, Minnesota, Missouri, Ohio, and Wisconsin. I got them all. We have a lot of supporters in this region. Actually, there are over 132,000 supporters in addition to 1,700 volunteers. So there's a strong voice in the Midwest. We need to make our voice heard because we have it.
Wow. Yeah, there are a lot of people who are very supportive. Thank you. And many of them are on this call. So we have supporters from all across the Midwest on this call. Can you give us some highlights of activities that have taken place in this region this past year?
Yeah, I'd be happy to. It's been an active year in medical aid and dying advocacy. Last session, we had medical aid and dying legislation introduced in Indiana and Iowa and Minnesota. Because of the current composition of state legislatures, it's unlikely that medical aid and dying bills will be passed in the short term in these states, with the exception of Minnesota. In Minnesota, our team, which is led by Dr. Rebecca Thoman and Gina Gentry, they continue to advocate for a hearing on the End of Life Options Act, which is already in the legislature in the House or Senate Health Committees. And with the recent shift to a blue trifecta, many issues that have lingered for more than a decade in a split legislature are now competing for attention and action. So We do hope to be on the short list of issues raised during the 2023-24 biennium. Our success really depends on advocates being willing to speak up. Lawmakers respond to the loudest voices. We all know that, and we need to demonstrate that Minnesotans care about medical aid and dying. It's a really active group up there, and we are building a strong base. In Iowa, in addition to the legislation that was introduced in the House this past session, there's an active group of volunteers who launched a quarterly Finish Strong series. This is on topics like medical aid and dying, dementia planning, advanced care planning, and other important topics. This is really a dedicated group of people who are really working on a lot of those cultural issues that we've been talking about. In Illinois, while a bill has not been introduced recently, we are heavily engaged in activities to set a pathway for success for medical aid and dying legislation. We have been for several years co-leading a statewide coalition with the ACLU of Illinois and Final Options Illinois. Last November's election was really a game changer, resulting in a supermajority for Democrats in the state House and Senate, in addition to having a governor who's Democratic. There are 37 newly elected legislators from the election, which is a large number. And we've been focusing most recently on educating them, as well as incumbent legislators, about medical aid and dying. And we have been meeting, it's been wonderful. We've had supporters in their districts joining us in these meetings, and we are targeting both Democrats and Republicans and working to really build the base of support within the legislature. And we want to thank everyone who's been involved and encourage anyone in Illinois who would like to work on this to contact us. But let me get to the bottom line, because I know everybody wants to know when a bill will be introduced. So do I. I really, really do. But I can tell you this, I am feeling cautiously optimistic, and we're working closely with legislative champions who are in leadership positions. So I will say, though, and this is something that was mentioned by Kim, and I think it's important, I am mindful of the tremendous opposition that's been organized and is continuing to grow in response to our progress. They are sophisticated, but that doesn't mean they're insurmountable. That's why we need your voice and support. Outside of medical aid and dying advocacy, we are concentrating on community education, a lot of focus on advanced care planning and dementia planning. And we have many tools that we want to make people aware of that are free and online. Just to give you an example, we have collaborated recently with the Illinois NAACP State Conference and 8 of its local branches to co-sponsor a National Healthcare Decisions Day presentation by Donna Smith, and she is our wonderful diversity and inclusion advisor and a state director. We also led a successful letters to the editor campaign about medical aid and dying and advanced care planning, which resulted in at least 8 letters being published around the state this year so far. And then shifting from Illinois, we are also building a base in Michigan in response to a more favorable legislative climate. We have formed a statewide action team of volunteers to educate and recruit volunteers. We offered training on medical aid and dying to Michigan supporters in April, and we will be assessing next steps over the summer and the fall. So I've been talking quite a bit. I'm going to take a sip of water, and you can ask me the next question.
Okay, wow, so much has been going on this past year throughout the Midwest. And what about the upcoming year? What are some of the plans for moving forward?
Thank you. Yeah, I would say we're building on the progress and the real progress we're making in the Midwest. Our legislative focus will be in Illinois and Minnesota. Nothing's guaranteed, but we are hopeful that conditions will allow for a bill to be introduced in Illinois during this election cycle. And as I mentioned, we're also building a base in Michigan. For those in other states, and I know many of you are in other states, I just want to say that these victories will be victories for you too. We need that first state in the Midwest so we can gain that kind of momentum. I hope that you will support that work and be a part of it. And it's important to remember that our movement is broader than medical aid in dying. We need to change the culture around death and empower people to chart their own journeys. That can be, and I think it is happening in every state. I've been here almost 5 years. I've seen tremendous change in our country, in our attitudes around death and end of life, which is not the same thing. So I stress to you that you can make a difference in this movement, no matter where you live. I'm feeling like this is going to be a great year. I'm feeling very optimistic.
I am too. And it really, one of the things that makes me feel so optimistic is the number of people who are on this call today. And it's fabulous. Well over 100 people from throughout the Midwest. It's really, really wonderful. What is the hardest part of your job?
I say knowing people who have terminal illnesses or have loved ones with terminal illnesses are counting on us to deliver. It's both an inspiration and a weight. Related to that is losing advocates and storytellers who are beloved partners and friends to me. There have been some losses recently that have felt really like a gut punch. And I have to say, though, I'm fueled by our advocates' passion and reminded every day that our work is intensely personal, both for us and for our supporters. And it's also very comforting to realize this is a movement. This is not one thing. This is a bigger movement. So I'd say that's the hardest.
Yeah, no, it is. Well, thank you. Thank you, Amy, very, very much. And thank you also again to Kim. I am going to now turn to some questions that we have in our chat. So I will, some of these. How does Compassion and Choices address dementia, Alzheimer's, Parkinson's, ALS, mental and other mental disabilities and other long-term conditions when addressing end-of-life choices?
It's a great question. And it is an element of our strategic plan that when I was going through, I didn't specifically mention. So under improved care, one of the elements of our strategic plan is gaining greater acceptance about the use of advanced directives for a person to be able to document their preferences should they end up getting dementia. And this includes their preferences to forego treatments and to not end up with aggressive treatments taking place. If you look at the issue with dementia, 1 in 2 people dies with or from dementia now. Whereas if you look back 50, 100 years ago, people were dying from diabetes, from dehydration, from disease. So as we've gotten really good at extending life, we are no longer able to kind of keep the mind alive. And that's what's resulting in such a shift towards people dying with and from dementia. So we can actually reverse that. I know a lot of people's focus is on euthanasia, people will go there. And in our country, in our political system, with our economic system and our, that would be a really challenging. But the reality is that if people make the decision, which you're legally allowed to, not to treat other diseases, we can cut the number of people who are dying with and from dementia astronomically and shorten the length of time people are living in a state of advanced dementia. So, but the challenge people have right now is they don't even realize this is an option. And then you're up against a medical system that is so bent on extending care that it takes strong advocates to counter the kind of force and the weight of the medical system. So we're really working to gain greater acceptance of the use of advanced directives to document people's preferences so that it will be accepted within the field of medicine, and that people in our Empower Consumers people aspect of our work understand what they need to do to be in a position to have a loved one advocate on their behalf. So where our focus is really on integrating advanced directives into the standard practice of medicine through demonstration projects, through the looking at regulation to see what are the regulatory barriers that are causing unintended consequences as it relates to dementia, and then empowering more people to use the dementia advanced directive values and priorities tool that we have so that they are charting their own course. And then for those people who really know that they don't want to have dementia, you do also have the legal right to voluntarily stop eating and drinking. And so we're supporting people around how you access the legal right to voluntarily stop eating and drinking, if that is the option that you want to do, and have a campaign around that as well.
Great, thank you. I'm going to go ahead and answer another question. People are asking about names to contact to get more involved. And also there's another general question about how to find somebody who can make a presentation at someplace. I want to let you know that the very last slide, or one of the last slides that we have, so you'll want to be ready with pen and paper or with your phone to take a picture. We will have some emails for us, and you can contact us and we can make sure that you get routed to the right place. So very good question. Thank you so much. Let's see. We are asked every time we make a medical appointment if we have an advance directive in place, and we do, they say, but how can we make sure that it is honored?
That's a great question. So would you want me to answer this, Amy, or do you want to?
Go ahead. I can jump in
Sorry,
later.
I jumped right in and then I was like, oh, any of us could answer this. So the most important thing with your advance directive is to make sure that you have identified a really strong healthcare proxy who's going to carry out your wishes and understands what those wishes are. And I think the default for most people is to assume the best person to serve as your healthcare proxy is your spouse, your partner, or if you don't have a spouse or a partner, your child, like whoever your closest loved one is. And it could be that that's the right person. So do not hear me say, walk away saying, oh, Kim says it shouldn't be that person. It may be that that's the right person, but I think you really want to step back and think about it. What you want is a person who's going to be in a mental place that they're able to make rational decisions, that they're able to separate out their interests from your interests, and that they have a strong enough personality to stand up to the medical system and to somebody, and they're not going to kind of cave under the pressure. And also that they're going to be able to keep others in your community who might be involved in line with what it was that you wanted. So those are kind of what you want in the healthcare proxy. And it could be that that's your loved one, but it's something to really think about, because oftentimes that loved one is so clouded with their own grief that they're not in a position to be able to really act on your behalf. And they may be better off, having somebody kind of there helping them through it. So that's something to think about. In addition to that, it's really important that you have those conversations with your doctors and providers in advance, that they have copies in their files. That is super important. If you're near a hospital, send it to your local hospital so it's there in their records. You want to increase the likelihood that that's going to be kind of where you go. And have it, they say, tape it to your refrigerator. Make sure if you have a do not resuscitate order, it's in the right color paper for your state. Sometimes it's yellow, sometimes it's red. Every state seems to be a little bit different. And then I would say you want to be sure that all of your family and friends, anybody who might be coming in at the end of your life, that they are aware of what your values and priorities are. And this is really, really, really important, because what happens all too often, and we hear about this all the time from providers, is there's this phenomena called the swooper. And the swooper is often a person who loves you very much, but hasn't been around later in your life as you were getting older. And then all of a sudden they get the phone call that you're dying or you're near death, and they swoop in at the last minute, and they think that their job is to save you. and they don't really know what you want and don't understand everything that you've been through. And they are actually the ones that have the loudest voice and convince more care to be given, and that may not be what you want. So to be sure that everybody's really clear about what you want and that you have those conversations in advance, because the hospital, the health system, they're going to listen to the loudest voice. There's no going back from, taking care away from somebody, and they're afraid of being sued. And so the more that everybody is on the same page, the family is on the same page, the less likelihood that somebody's going to do something that's inconsistent with what you would want. And I feel like I'm missing a really important point. What have I missed, Amy?
Well, I just want to add that I don't know if I'm going to do what you've missed, but I'm going to add. I think it's very important when you're talking to family to make sure they understand the role of your proxy or power of attorney, and that person is the person. It's not enough to have it in the document because of the swoopers, and just because there's going to be conflict sometimes, and it's always good intention, but you want peace at this stage. You don't want conflict in your life. So I think that's a really important piece of this. The other thing is, you're not going to be able to think of every possible scenario and document it. So it's very important that you think about generally what are your priorities, your values, and have those kinds of conversations with this person who's going to be representing you. Remember, you don't use this person. This person doesn't activate, so to speak, until you're unable to speak for yourself. But it's not just one conversation. It's not just this document. It's really kind of a series. So I think that what Kim's advice was about really being thoughtful, it's the most important thing you can do. Finally, I will say it's great to spread your advance directive everywhere. I'm serious about this. I have it in all my portals, all my doctors. I have all sorts of conversations. It doesn't hurt to have it even, particularly if you have a physician's order for life-sustaining treatments, a POLST or a MOLST, having that on the back of your door, all of those things. But in the end, what's probably most important is for them to know who your healthcare representative is. And one of the things that you might think about doing is putting in your wallet, my healthcare representative is blah, 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 blah. Here's how you contact. I'm even thinking getting a bracelet, but that's just me. So think about how do you get that information to folks, to
and
people.
those are all phenomenal points, Amy. Really good. Let me add two more things to that, which is that one of the biggest challenges people have at the end is if you call 911, they come and they are all about resuscitation. So if that is not where you are in your disease trajectory, you want to really understand what should you do, when the emergency ensues. And so if you have hospice care or palliative care involved, often there's a phone number you can call for them, and they can help your loved one sort of know, is this, time to call 911, or is there a better way to handle this situation at the moment? So that's really important, because if you can avoid going into the emergency room, you can often avoid the suffering and the kind of increased care that is often not what somebody wants when they're really nearing the very end. And then I just want to underscore what Amy talked about with POLST and MOLST. If you are in a state that has physician's orders of life-sustaining treatment, or also called medical orders of life-sustaining treatment, and you are frail or have a terminal illness or a very serious or chronic illness, in addition to filling out your healthcare proxy and your advance directive, you should also talk to your doctor about putting a MOLST or a POLST in place, because a MOLST and a POLST is a medical order. It covers your care. And it doesn't just go in effect when you can no longer speak for yourself. It governs the kind of care that you're getting towards the end, and helps to really ensure that it's that you're getting care that's consistent with your values. And so that increases the likelihood that you will get the kind of care that you want. They do not have MOLST and POLST in every state, so you have to check your state rules. But if they do have them, it's worthwhile if you are frail or have a terminal illness.
Great, thank you. Thank you, both of you, for that great response. Shifting a little bit to the legislative side of things, we have a question of something that just happened last week. Somebody asked, I see that Nevada just passed medical aid and dying legislation, and I've lost the question, and the governor did not sign it and was wondering what caused that to take place.
It's a great question. So unfortunately, while death is not partisan, and support for medical aid and dying is partisan, is bipartisan, to people, and you have, vast majorities of Democrats, Republicans, and independents all wanting the option. It's still very polarized within our healthcare system, and within our political system, I should say. And the support for medical aid and dying at the moment often follows the parties that are the Republican Party often gets a lot of its funding from the Right to Life and the Catholic Church. And my belief is that the governor allowed, you were in the state of Nevada had 84% support among the general public for medical aid and dying. But the governor happens to be, get funding from the Catholic Church. And ultimately, he chose political party over what the people of his own state wanted. And so it's really unfortunate. He's the first governor in the country to veto the legislation. We are going to continue to work to make sure that this issue is not partisan within the legislature, because it's not partisan to people.
Right. If one has a living will, does one also need to have an advance directive?
You go ahead, Kim. I want you to have the final. Is this our final question?
We might have one more, maybe. So an advance directive is part of a living will, like they're yeah, it's part of the living will.
Okay, right. And what happens?
Before you do that, I just want to add to that. Sorry, my cat is trying to get my attention by knocking folders down. This is really fun. But I just wanted to add, in terms of the living will, just if you do one thing, make sure to get that power of attorney done, the durable power of attorney. We have a lot of great resources. We have a planning center online, and it actually even has, like, by state, like what you need to do. So if this is something of real concern, I would recommend you check out that planning resource. We have this wonderful end of life decisions guide, which I think is, I use it all the time in our work, that helps you kind of think through, because I think for a lot of people, even this planning is difficult because they don't even know what they want. So that's another really great tool. I just encourage you, check out our website for a lot of this. And also, we've done webinars during the pandemic. It feels like yesterday and 100 years ago in some ways when this happened, but we really thought about what can we do to add value given we can't meet person to person. We did this series of webinars that are really quite good, and there's a lot around advanced care planning in that. And you can get all of these things. I think it's on our website or it's on our YouTube channel. So please check it out. If you need help, let us know.
All right. I'm going to ask one more question. It's for Amy. There's a thank you for your summary of all the progress in the Midwest. You mentioned collaborations with ACLU and NAACP. And the question is, are there other opportunities to forge alliances that could advance Compassion and Choices goals?
Yes. And you can help us. I don't know what state that person's from, but if you have connections, let's say the Rotary Club, let's say League of Women Voters, let's say the University Women, the UUAW, I think it's called. All of these, your churches, your temples, your civic clubs, your friends, these are all ways to make alliance. All of this is about building a base. And, I've been doing a lot of work, not only in the NAACP in Illinois, but also we've been doing a lot of outreach to LGBTQ organizations, those that are serving Latino populations, other special populations. Another one is really, if anything you can do that helps us make more connections with those that are working around disability rights. We really want to engage in conversation with disability rights groups. Some have concerns around medical aid in dying, and we really find that if we're able to build trust and talk about this, we want to engage in that conversation. So there's so many ways, there's so many opportunities out there, and it's more of a matter of capacity and connections. And so that's where you come in. I know I keep putting it back on everybody out there, but we do need that, we need that partnership with you in this. So I hope we can work together. I'm gonna turn this, I think, to Karen. I don't know if we have more time, but I really want to make sure you know how to connect with us.
There we go. Absolutely, Amy. Thank you. And with that, we will, I see that we have a slide showed up. This will show you how you can get involved to, help us in the movement in the Midwest, connecting us to organizations, as Amy was just talking about, and a whole variety of other ways. So we welcome all of you to be volunteers in this movement. The best way to do this, to get started, if you have not yet, is to sign up at Compassion and Choices. So it's compassionandchoices.org/volunteer, or there's a shorter version, cnc.org/volunteer. You can sign up there. If you are in the Midwest, and I am assuming that most of you are, I will personally be in touch with you, and we can talk about more specific ways for you to get involved. Also want to make sure that you know that about upcoming events. Again, this link at the bottom, cnc.link/upcoming, will always take you to a place to register and learn about upcoming events. The next one that we have coming up, however, is a virtual webinar that will take place on Wednesday, June 28th, called As the End Nears, Dying with ALS. And that is a webinar. So, and finally, Compassion and Choices, we touched on this earlier, but Compassion and Choices is funded almost exclusively by individual donors like you, who are committed to the issues of end-of-life care and having options. We invite you to please consider making a donation today to help us expand our work and ensure that everyone's priorities and values are met at the end of life. Every donation of any amount makes a difference. And we often say that financial support is a form of activism. So if you are in a position to contribute, you can go to our website at compassionandchoices.org/donate and donate online. There's also a shortened URL that you can see on that slide. And if you have any questions, you can please contact Amy Sherman. And here is the slide I was telling you about. There are contact information for Amy, for myself, and for Kim are all there. And so please send an email to one of us. We will definitely make sure that it gets to the right place. But if you're interested in volunteer activities, kind of things, you can send that to me. But we will all make sure that the right person gets the email. So thank you.
Jump in, may I just
Yes.
quickly jump in and say, for the
Of course.
Minnesotans, who I think I've seen a lot of questions about, we have a team, Dr. Rebecca Thoman and Gina Gentry. And so if you do email to Karen, she will get you hooked up there as well. And there's a lot going on in Minnesota. So we'd love to get you engaged as well as everyone here.
Absolutely. So thank you. Thank you again, everyone. Thank you to Amy. Thank you to Kim. Thank you to Patrick, Don, just behind the scenes, making sure that this all works for us. So We look forward to seeing you all again.
Thanks, everyone.
Thanks,
Bye-bye.
everyone. Thanks, Karen. Bye-bye. Have a good night.